Thank you for the introduction. Happy to be here. Here's my conflicts of interest. We do a lot of funded research with a few different CT vendors. I don't receive any personal money from any CT vendor, though. Okay, so the point of today's talk is to talk about how to modify protocols across vastly different patient sizes, right? From tiny little newborns, like the diameter of an Nalgene water bottle, say, to bariatric patients that perhaps we have trouble even fitting inside of our CT scanners. So not only are some of the indications that we worry about imaging with these different patients, they can vary, but obviously the size and the amount of dose that we're going to need to deliver is going to have to drastically change across this wide spectrum. So when we talk about patient size, though, I think there's technologists, there's physicists, there's physicians, radiologists, all involved in radiology. And we might be thinking about this in different ways, right? Physicists I like to think of in terms of like this tissue thickness or effective diameter, water equivalent diameter. That's kind of foreign to a clinician who's used to administering therapies and drugs, maybe based on weight or BMI, and then classifying patients based by age brackets and if they're bariatric or not. So we kind of have to bridge this gap. And I think as a community, just be aware that the technical folks might be thinking on the left side, but we have to definitely translate it always into something on the right side for our technologists to utilize. So there are ways that you can go between some of these various different size metrics and the various levels of complexity and modeling, like I'm showing here on this table from my textbook, just comparing some water equivalent diameters to some geometric size surrogates, like just measuring the patient thickness. All right, but let's get back to like some images here and what it really looks like to vary dose across patient size. So here, I'm showing some examples. From left to right, we're going from small patient up to a big patient. You can see here, I've got the milligray that was used at my institution, as well as the patient size in centimeters. This is their AP and, their lateral by their AP dimension. So right away, we can notice like there's a big dose doubling here, and we can see that that happens on this particular scanner in this protocol, and the patient size went up by about 8 centimeters. And that's pretty consistent across the range for all of these patient sizes. So we can make a lot of conclusions from this, but one of them is just, this was all one indication, routine abdomen pelvis at my institution. And I think it's just really important to know, A, there's a really big range of doses that we would consider appropriate to image those patients. And then B, the dose changes a lot with patient size. All right, so my kind of advice here, if you're a radiologist or a technologist, physicist, anyone out there, don't kind of have like one number in your head about what's an appropriate dose for a protocol unless you know what size that dose is associated with, because as soon as you get a little away from that patient size, that dose level could get is gonna differ by a lot. So that's kind of what I'm plotted here. So what this plot is one of my favorite plots I've made. Basically, it shows those two things, that as we go up in size, okay, for one protocol, routine abdomen pelvis, like I have here in salmon color, the dose is going to drastically vary. And that amount of variation is going to be much bigger than an indication to indication variation. In other words, if I take all my patients and look at virtual colonoscopy, or all my patients and look at routine abdomen, or all my patients and look at spine and calculate the median doses, that range isn't going to be as much as one of those indications, just varying across all patient size. All right, that's something I think, we don't think about it enough, but that's definitely going to be true. And that's just because the exponential attenuation that we have, unfortunately, with patients, that in order to get similar levels of image quality from a newborn to a bariatric, we're going to give many, many hundreds of percent more dose for those larger patients compared to our smaller patients. But additionally, as long as if it's kind of a more foreign concept to think about this across different patients, I think especially if there's any radiologists, in the audience here, it's a lot easier to think about within one patient, right? Everyone can scroll through one patient and see size that changes and know that usually you can see some kind of a readout for what the scanner AEC is doing, and you can appreciate big differences in the patient size there, and then the MA correspondingly adjusting up when we get bigger sizes. So when we notice that we can start to appreciate if we start to look at aggregate dose analyses of dose versus patient size for a protocol that has a problem, we might start seeing something like this. So by having a problem, I mean we've kind of flatlined out in our dose up here. In other words, probably the scanner would have wanted to give more dose for these larger patients, but it wasn't able to, so it kind of flatlined out. In other words, everyone over like 40 centimeters effective diameter on this plot here, we're all getting the same dose. The scanner has reached its maximum. It can't do any more. We're going to talk more about using dose tracking to help optimize things, but I just wanted to kind of introduce these concepts at this point. Okay, so patients need, let me just check. Okay, so larger patients need more dose, but isn't that what the AC already does, right? Like, do we need to worry about this? Yeah, we do, but there's a lot of options, all right? So we're getting to a stage now where on some state-of-the-art scanners, and I'll show an example, have pretty advanced AC algorithms that work pretty well across really big patient size changes, but most of the scanners that we're going to see in practice today are not able to do that. So to kind of motivate this and get thinking about how to set up doses across patient size, I thought it'd be best if we did it. So let's just imagine here we have 3 different patients, a pretty small person, maybe an average size person, and then a bariatric person. And maybe we kind of know a priori, we have like these dose targets that we want for them of like 2.7 milligray, 10.8, and 58.5. So let's first think about what kind of kV we would use to image them, or what kind of beam energy. All right, so this is how I like to think of kV. This is a pretty early on paper, pretty foundational paper to understanding beam energy. So when we're changing beam energy or kV, I think the 2 things we should be thinking about is when we raise kV, we know we're going to be lowering the noise for the same dose usually, and that when we lower the kV, that means we can get better image contrast, and a lot better image contrast if there's iodine on board, and maybe slightly better for most of the other soft tissues. So maybe for that example that we're going through, that's not a CTA type of an example. We could think of that as more, we just really want some low noise so we can see the soft tissues. So in this paper, they would call that a density task and not an iodine task. And there what you can see is for most different size patients, right, those are these different data points and lines, the optimal CNR happens at higher tube potentials. So what in practice we would operationalize that usually is we would stick to our higher kVs on the scanner. So instead of using like 70, 80 or 100 kV, we might use 100 kV for that smallest patient, and then 120 for that average patient, and then 140 for our largest bariatric patient. All right, but we're going to have to change more than that, right? There's more buttons and knobs we've got to set, like pitch and rotation time. So we're going to do that next. I had this plot in here just to point out if this was a CTA, that's when you start getting the optimal CNRs being prescribed by some of the lower kVs, like 70, 80, 100 kV, depending on what stations you have available on your scanner. Okay, so back to those other parameters like pitch and rotation time. Now, for that, even at 140 kV for that bariatric patient, if I tried to image that patient very fast at a very high pitch, say 1.5, and a pretty fast rotation time like 0.28, we might only have a maximum dose possible of 11 milligray. And that would be using the maximum MA that scanner has. And the reason is because we're scanning just too fast. We can't pump enough photons into the patient when we're scanning at that fast speed. So we're going to have to slow it down a little bit. In this case, say if we were to do 0.5 pitch and a half-second rotation time, and that's how we could get out a maximum dose of 61 milligray. So this is definitely, we're going to talk a lot more about this in the next few slides, but fundamental concept to understand is that you can't just optimize the kV for the patient size. We've also got to think about how fast our scanner is scanning so that we can get enough dose within the MA limits of the scanner. All right. So this is actually one of the CE questions here, and that is the highest dose will correspond to low pitch and long rotation times, essentially slow scan speeds with high MA. I want to make a quick little point, though, that we can still have low pitch and long rotation time and low dose, though. You just use a lower MA value. A lot of people, fundamentally didn't get this. So we wrote a paper, one of my colleagues and I, a handful of years ago, just to talk about this, that yes, you can use a low pitch, and it's not horrible for the patient in terms of overdosing them. You're just going to be using a lower MA station. So you really shouldn't think of pitch as your like primary dose knob. If you are thinking of that, maybe you were just trained like, before automatic exposure control was a thing. But nowadays on a modern system, the scanner can usually pick an MA value that's going to allow you to use a lower pitch if you wanted. Okay, so that's what this would look like then if we tried to optimize the scan speeds, and within the MA limits of a scanner, we might have a setup like this for a kind of a routine protocol where we have our smallest patients, maybe we're scanning quite fast, like 440 millimeters a second. Our average size patients, about half of that. And then our largest patients, we might be scanning them a lot slower for that bariatric size, right? That's a big difference, 80 millimeters per second versus 437. But where we need to get a lot more dose out. All right, so the dose is going to have to go up and the speed's going to go down. So this was a figure I made a while back just to kind of conceptualize this, that you've got all these different patients of different sizes. And so as we go up here, patient size is going up. And there's kind of an area of this plot where you can't really image those patients. So at really fast scan speeds, some of these larger patients, just kind of impossible to image them. So this is kind of how I like to think visually about these things, right? Or graphically, if you will. So when I have a large patient, I need to stay at slower scan speeds in order to get enough output, right? I'm plotting here. This is the output that I have available. I can only really get away with those really fast speeds when this patient is smaller. When you're on a Siemens, they're the only vendor, so I use them by name, but that has a dual source technology. You have the same thing there. You also have a little bit of an issue with the changing of the field of view. However, luckily it actually kind of works out pretty good, because when you scan really fast on that platform, that's when you have a smaller field of view, but that's usually also then when you'd have smaller patients. So that kind of works out pretty well. All right, so the next comment I wanted to make about that is, if you're going to get anything from my talk and go in the clinic and really implement some of the stuff, there's some other things we got to know about. And that is that if we scan for too long, we might also have issues with our tube output because we can't use high MA limits, right? So if you scan too slow, you might have to keep your MA low so your tube doesn't melt. So here's I'm showing from one of the CT vendors, their manual. Basically, they show that the maximum MA goes down the longer your scan is. And this is a real consideration, right? If we're going to do like a chest, abdomen, pelvis scan or runoff scan or a bunch of different scans, they're going to have a nice big tens of centimeter scan range. We are going to have scan times on some systems that can be in the tens of seconds. So our MA ceiling could really be hurt by that. So for those kind of scanners that might be a little older and not have great tube limits, you really want to make sure, if you're running into problems here, that you're using the widest beam collimation possible. So this is another one of my CE questions, that if you scan too slow via using a beam collimation that's too small, you might find you can't use a high enough MA. And this is just because the CT vendors are trying to protect their tubes by keeping them from melting at high MA values for too long of a time. So here's just make it clear. Here's an example, right? You might have like a 0.5 meter scan range if it's at 0.5 pitch at 40 millimeter beam collimation, and you could do that in 0.40 seconds rotation. Great, scan time's 10 seconds. But if you've got that same scanner and you just ported over or copied over the protocols, maybe from the 10 centimeter scanner that was its predecessor, you might have a protocol that uses a pitch of 1 and a 10 millimeter collimation and a 1 second rotation. That would take you 51 seconds. Not a very good place to be. Okay. So more on this theme of scan speed and dose. These are some protocols that I've mocked up that are pediatric specific, which is a really, really important place for understanding this, because for adults, you could tell the adult, if it's just like a routine outpatient or whatever, hold your breath, maybe. And they're fine holding that breath for a few seconds or 15 seconds. But you're not going to get away with that with little newborn or little kids. And you really don't want, one of the benefits of CT is that it's fast and you can avoid sedation, right? But if your scan's taking a really long time and the kid's moving, we still might have peds sedation. I mean, that's common, right? Still in the CT setting. But if you take advantage of really fast scan modes, you actually can mitigate a lot of the need for that. We did that when we got our first wide axial scanner at my institution, where we could scan basically multiple times faster than any other scanner in our fleet before that. And we started rolling out these sedation-free PED protocols. But anyway, back to this slide. What I'm showing here in the box is the height of the box is the maximum dose this protocol is able to do. And I've overlaid that on the dose curves that I need for various size protocols for my newborn, my 6-month-olds, my 3-month-old, etc. And what this is kind of telling me when I'm setting up these protocols is like, okay, in order to image up to this type of size protocol, I need X amount of dose, right? That's somewhere on this curve. Okay, here's a laser pen. So this box, where it intersects this top curve here of the top CTDI of all I need as a function of all these patients, that's the limit at that protocol. I can't go to the right anymore. In other words, the protocol as it's set up right here can only go up to patients this size and below. Over that, and the MA would start to max out. Here's just another example of a different type of a scanner. This one was a dual source scanner. It's actually way faster than this one on the left, but it has a lower maximum dose in the way I've set this example up. So this would be better for scanning faster, but it wouldn't be as robust in terms of being able to scan as many pediatrics. You'd need to slow it down a little bit if you wanted to scan as many. So I'm not making some comment here about what's a better technology, dual source or single source. I don't want to do that. I like, they both have merits, pros and cons, but in this example, just making sure that you're aware that there is this fundamental relationship between the maximum tube output and how big of a size pediatric you can scan. All right, so let's make this like actionable. All right, this is just a talk, like what could we really do with this information? Go to your scanner, right? Enter the highest possible pitch value, the smallest possible rotation time, the smallest KV, right? Like, let's build our PED newborn protocol. Enter your largest MA and see what your scanner can do for output, right? And if you know like what kind of doses you expect to have for your pediatrics, now you know like what size PED that fast pediatric protocol could go up to from doing this simple little exercise. You can save that protocol, call it PED newborn to, I don't know, 8 years old. And then you would know, okay, if I'm going to use my 8 or my 9-year-old to 12-year-old, I'm going to take that protocol and I'm going to slow it down a little bit. You could lower the pitch a little bit, or maybe increase the rotation time, either one of those, and you could use that protocol for a little bit bigger size pediatric. So that's just some actionable advice there to operationalize that. All right, so another CE question: if a protocol is optimized for small patients, that may have issues with large patients because it would hit an MA ceiling. So kind of sacrifice dose maximums with our need for speed on small patients. Okay. So now, how do we adjust protocols to adapt to patient size? All right, so I'm going to just go over like a few different options that one could have to do this. Some of them are like at scan time, maybe not the best idea, and other ones are more advanced. So, all right, so here I'm kind of, I'm showing this picture of a technologist at scan time. They got a lot that they're worried about. Okay, that's not a place I like to be talking to a tech at scan time. They're busy, they're trying to focus on their patient. The last thing in the world they want to think about is a bunch of physics parameters, right? They want to focus on, okay, contrast volume, how's that venous like access, what's our scan timing for this protocol again? I better make sure I coach that patient and explain to them what's going to happen to them over the next several minutes. How am I going to bill this patient? When's my break? Or, I got to use the restroom. Like all sorts of human things that are not related to physics. Okay. But when it comes to the actual physics stuff, like they have a lot of complicated things that we might be asking them to think about. Their KV, the MA limits, rotation time, pitch, noise index. Okay, so you could ask them to set all of these, and I really only know of like 1 or 2 places in the world where they do this kind of really bespoke protocol creation, at the scanner side. I really would not recommend this because it's kind of like a craft, right, to come up with all these parameters, and they're probably not going to do it the same way every time. So this is not really a good option to kind of figure this out and set it up at scan time. Okay. All right. So the next one is, sorry, I saw that it looks like folks, you can put in questions, and then I think we have time at the end. Yeah, okay. So the next one is option 2. We could just pre-build these into the scanner, okay? That's how like we've done it at Wisconsin. I think this is the most common way, where you pre-build what you're going to do for small, medium, and large patients for each indication, pre-built into the scanner, so the technologist can just, they know what they need to image, biphasic liver, they can size up their patient, and then they can pick the proper size protocol from the scanner. They're not doing any physics, okay? They're just either eyeballing the patient, which in reality is how a lot of technologists would do this, or maybe after they take the localizer, that's the Scout, topogram, SurView, whatever you want to call it, they can measure, take a few measurements, and then change the protocol to reflect that patient size. It does get a little bit crazy because you might have a lot of different protocols, and then you might have a lot of different size ranges. Like I'm showing here, you might have a lot of different pediatric sizes. We might have a lot of different, a few different adult sizes, maybe even a bariatric option. You might have hundreds of protocols then on your scanner if you really flush all of this out. This is what I see a lot of places doing, though. This is what we've done for years. Option 3 is you use something more advanced. So I'm just going to talk there. This is one vendor's, I think I tried not to keep their logos on here, but this is like one vendor's implementation. Okay. But there are other vendors out there that have like these kinds of more advanced systems. I'm just going to talk about one here. But basically what this vendor lets you do is predefine these different patient size buckets, and then exactly kind of tell the scanner what you expect it to do within those size buckets. So you can basically break up your patient size ranges into these different bins, and then set what all of these different parameters should be across those sizes. So this does too facilitate, depending on the vendor, you can kind of set up like typical profiles, if you will, or ways you want to do it. Like in other words, pitches you want across patient size, and then use those in multiple times in multiple places. This is one vendor's implementation. There are other ones I like, and there's pros and cons to all of these different solutions, but they all kind of get us to the same place. Other vendors might let you pick a profile that's going to change some of the pitch and rotation time things for you without you having to preset them up or think about it. So there are other solutions out there. All right, so I think like the last bit of the talk today, and then I think we'll have some time for question before 4:45 is I'll talk about how to kind of keep track and manage and optimize these protocols. So this is one thing that some of the audience might have heard us talk about at Wisconsin before, but I have some new stuff in here a little bit, but we'll review this master protocol concept. So what this master protocol concept is, it's a way to both optimize and organize your protocols across patient size. So what I'm showing here is, if we consider the same slice of anatomy, we could think of imaging at a really low dose, a little bit higher dose, a little bit higher dose, and even higher than that. And each one of those dose buckets would be good for a different task. So like this really low dose, that might be good for like a screening exam, or like just a non-contrast localizer to ensure that if we're going to do a subsequent like multi-phase angio of a certain organ, that we're on top of that organ. Above that, maybe just for like renal calculi, like stone burden, like where'd that stone go? It's a high contrast task. We don't need a lot of image quality. Above that, that might be kind of like our bread and butter protocol. And then maybe our highest dose bucket, that's used for like surgical planning, where we need to make like a fancy volume rendered image for a surgeon of like a little 1 millimeter vessel, and we need really good quality. Or it might be the dose level we use to do a trauma scan that we're also going to retro recon some reformats for the spine off of. All right, so when we do that, when we start thinking about these doses and using this master protocol concept like this, you get some benefits. So one of them I'm showing here, and that is you can have one kind of dose bucket that you use for multiple indications. So at our institution, we use the same dose bucket for routine head, orbits, and temporal bones. So this would all be one master protocol at our institution. There's a plethora of benefits, in my opinion, to thinking about this and organizing it in this way. While the recons might be different for each one of these, the scan range is basically the same body part, and therefore you can manage like looking at dose statistics very similar. You can estimate doses much better. You can have less unique sets of acquisition parameters that you're trying to maintain at your institution. You can also have then, though, different master protocols, dose levels over the same body region. So this was same body region, same acquisition parameters. You could hear 3 different master protocols over the same body region, like a trauma ped protocol high dose, routine ped protocol middle of the road dose, and then a low dose, like a pectus protocol, really low dose. Same body region, different dose levels. So this really just helps us not have to think about all of these things, these reconstruction parameter or acquisition parameters, excuse me, at scan time, and reinvent the wheel every time we need to build a protocol for a new indication. There's lots of ways to skin a cat. I think you should have some way that you do it systematically in your head. This is just from my book, one of the ways like we think about it at Wisconsin, but you could think about this, and this might be a little bit unique too to the technology that you have at your institution. But this is kind of how I break down what kind of pitches I'm going to use, what kind of beam collimation, and what kind of rotation times. This just kind of walks me through, like, do I need really good detail? And do I need to scan fast or slow? Is the scan range going to be long? And kind of flowing through some of these really simple questions can help you kind of pick what kind of parameters you're going to need for pitch, rotation time, etc. All right, so what do these parameters kind of really look like? Well, we might use, like, say, similar beam collimation across multiple different types of protocols. So here we're using like a 20 millimeter beam collimation for extremity and routine head, and then a 40 for ped body protocol and an adult body protocol. And we'd probably be using the same beam collimation as well across all patient sizes, because that would usually just make sense. But things we might be changing across different indications and across different patient sizes for sure would be our pitch. We've talked a lot about the speed up till now, and this is one of the main knobs. We have to change our maximum dose output limits is our scan speed, which we can adjust via pitch. I think I'll skip that. So here's just an example, and this is a paper you can get. It's open access of how we've binned some of the different indications at our institution. So there's a lot here, and we're not going to go through all of this, but I think it's just really important if you're going to organize your protocols and have any hope of doing this master protocol concept, you need to write it down. So here is how we do it. We kind of say, okay, what are all the indications and phases of multi-phase protocols that should look similar in image quality? And then we list them out like this. Okay. Oh, I saw a question. You know what? Real time, I'll just address some of these. Yeah, some of this, I'm not sure what, I put the updated slide sets for my talk today and tomorrow in their box today. So it might just take the organizers a few more hours or until tomorrow to get those slides up there. So good question. Yeah, sorry about that. Okay. In other words, the question was, the slides I'm showing right now are not in the box, but they will be by the end of the meeting. Don't worry. All right, so we do the same concept for all body regions. Okay, so I just showed you abdomen or body, torso, if you will. This is for neuro. We have the same thing. We do it in the cardiovascular section. We do it for our PEDS protocols. Okay, so when you start thinking about them like this in terms of this master protocol, this is when we're going to bring it back to actually like optimization now and variation with patient size. So when we're trying to vary these things with patient size, we really should be relying on output plots. So most people that I speak to, you know, they have some sort of commercial dose monitoring system. There's usually some way to make that dose monitoring system create a plot like I'm showing here. Here I'm showing CTDI vol as a function of some size surrogate. Okay, all the size surrogates out there, like water equivalent diameter, effective diameter, AP, lateral, I'm probably missing a few. They're all pretty much going to be, they're going to be monotonic with each other. So as long as you can get some sort of a plot of a tube output, in this case CTDI vol, versus some kind of a size, you can do the important work you need to do to make sure that your protocols are tuned across patient size. So, all right, with all that preface to this slide, let's actually talk about what I'm doing on this slide. So this slide is showing the reference full dose, regular dose, routine abdomen protocol for our small patients with these blue circles, for our medium patients with these like little red pentagram things, and for our large patients with these yellow squares. All right, so that's from a few hundred patients plotted out. So once I have that information, I'm like, okay, this is good. I know that protocol, I'm looking at it, it's really not maxing out that much. Maybe I have some issues over here with these patients, but that's really bariatric. Let's not worry about that. Most of my patients are going to be in here and everything is looking okay. Now that I know that, though, I can use the settings or whatever technique I had set up for this routine protocol to help me build other levels of dose or other master protocols. So here I have an anticipated need of a virtual colonoscopy protocol. Maybe that protocol is, I want to be half the dose out of the gate of my routine abdomen protocol. Well, if this routine one wasn't maxing out and I adjust the dose knob, say my noise index or my effective MAS or my SD value, whatever, pick your poison in terms of what vendor you have, to half my dose, I'm definitely not going to be dosed maximumed out with that because I wasn't maxed out to start. But if I wanted to do, say, like a trauma protocol, which is going to use double the dose, then I can say, okay, what kind of MAs was I requesting up here for these largest patients? If I did nothing other than double the dose via the dose knob, am I going to be over the limit of MA on that scanner? And if the answer to that question is yes, in order to get to, like, say, this example, theoretical red curve, then I know I got to do something. And that something would be to slow down that reference full dose protocol in order such that when I double the dose value, I'm not going to run into any MA limits. Okay. So this is more examples of me pulling some of this information from, this last one was from kind of a homebrew dose monitoring system. These blue plots are from a commercial dose monitoring system. So this is really what you want to be looking for, right? If our scanner is maxing out or minning out, because when that's happening, we know we're not providing our radiologist with the proper level of image quality, right? If we're having an issue with it maxing out, that means that the scanner wanted to give more dose, but it couldn't. So those images are probably going to be too noisy, more noisy than they should. And then on the flip side, if it's minning out, we're giving too much dose, and those images better look pretty good. You know, hopefully no radiologist is going to complain when I'm minning out, because again, the image is going to be much better than the scanner, like, say, wanted it to be. All right, so I think it's really important, you know, to have kind of analytics like this, because you can start to answer lots of questions and kind of do really more advanced optimization. So we can ask questions like, what size patient will our protocol hit an MA limit? So if I'm sitting there looking at my dose monitoring system and I see, okay, at 40 centimeters effective diameter, I hit a limit, then I know I got to do something. I'm either going to modify the whole protocol to go a little slower so that I can get more dose output up here, or I'll make a new protocol that maybe uses a higher KV, is a little slower than the old protocol, something like that, to get more dose output so that I'm not flatlined out like this anymore. So it's really important, I think, to be looking for these kinds of flat spots when you're trying to do this protocol optimization. All right, but that's kind of like experimenting on our patient population. We don't really want to do that. Can we do this in a prospective manner? All right, and the answer to that is, yeah, we can do this in a prospective manner. So we kind of have some idea how all the different CT vendors' automatic exposure controls are going to operate. So this is a table from my textbook here, and I'm just kind of detailing the 4 or 5 major CT vendors like our Canon, GE, Philips, and Siemens, and the relationships between those dose target knobs and what that tube output is on the scanner. So if we know just some basics on how that scanner is supposed to operate, then we can prospectively understand what that tube output is going to be when we make modifications to the protocol. So here's an example of me doing that. So this is from a paper on our master protocol concept. And here you can see, once we know the original MA limit of protocol we know is working, and we have some idea of what we know we want for our new dose target, we can plug it into this equation, and we can figure out what the new technique parameters for acquisition need to be for that protocol to not have an MA limit. I realize I might have lost a lot of folks on this, but this is an open access paper, or you can reach out to me if you want to be more prospective about this. You can do it this way, where you scan some patients and you have some problems, and then you make adjustments from there. But there is a better way, and that is just doing a little bit of prospective analysis. It looks kind of more complicated than it is. It's really just saying, hey, what's my MA that I'm using maximum today? I know I need this much more dose. Can I get there? Yes or no? And usually the answer is you just go a little slower in your acquisition parameters, and then you can get there. All right, so some of the actionable information on this is to sit down and list indication and protocol by indication protocol what should require similar levels of image quality and scan speed. All right, that's people always ask me, like, where do I start with all of this? That is the fundamentally most important thing that you're going to do. You're not editing any scanner. You're sitting down. You're talking with radiologists, if you're a physicist or a tech, or you're already a radiologist, and you talk with your partners and you say, okay, what do we expect indication and phases to have similar levels of image quality? And you write that down on a piece of paper. That can help you drastically reduce how many different things you're optimizing. We have this deck, say, for example, or this open access paper as a guide for how one could do that with some examples. Like, for example, you're probably not going to bin your virtual colonoscopy with your trauma abdomen, right? You're going to want a lot more dose on the trauma than you are on the virtual colonoscopy. So you wouldn't put those together. But maybe your cystogram and your routine abdomen, maybe those have a similar dose. Consider using a dose monitoring system's output as a guide to group together protocols that already have similar levels of pitch, rotation time, dose, etc. over the same body region. Yeah, so I've been talking a lot about using dose analytics, right, to make sure you're doing the right thing, but you might have some protocols that are not used very often. So if you have all this data, though, on different protocols that you knew are using the same acquisition techniques over the same body region, you can pool those together. So some of your more rarely used protocols, you can still do some quality control because, even though the indication may be different, they're using the same acquisition technique over the same body region. So yeah, tracking dose and MAS versus patient size is, if it's not clear already, I think it's just a must to do all of this. All right, so things I didn't get into a lot were like how to set the relative doses for indications. Here's just a paper we just got published in JCAT, where we compared the relative types of dose distribution we used for like routine and cancer imaging protocols at our institution and then at MD Anderson. And while we found that the doses were different that we just settled on between UW and MD Anderson, we were dosing our cancer patients more than like our routine patients by similar amounts. So I think this goes into I know there's other talks at this symposium on this, like regional or personal differences at different institutions, but you definitely should not have like all your body indications all at one dose level. So basically, I'm just making the point here that for the actual setting of doses between indications, that needs to be done by radiologist decision. So I don't really advise too much or worry too much about tweaking dose changes over a single patient size group and worrying about that, right? So I would just get it right for a single size patient and then let the vendor's AEC take over. So like, what do I mean by that? So like within reason, I wouldn't expect to, I would expect to tweak differently your targets for peds, small adult, medium adult, and bariatric, but I wouldn't like worry a ton about like your littler size medium adults and your bigger size medium adults and trying to like adjust vendor AEC and parameters to tweak that. That's kind of in the weeds. I will say I have nothing in the stack about pregnant patient protocol modifications because like they don't make sense to me. I listened to a little bit of the previous talk and you hear a lot of comments about making sure we're imaging pregnant patients with low dose. But then you also don't want to double dose them, right? So to me, if I already have a starting protocol that's going to work on a non-pregnant patient, that should be as dose optimized as possible. I don't want to do anything different to that protocol and then use it on a pregnant patient, which may jeopardize any of the quality there. So this really, from a protocol acquisition side, I would not change anything because I don't want to have that problem. Now, on an appropriateness criteria or what's the best modality to image, that's a separate question that I won't get into on this talk. But there'll be some more on this, especially related to PE, because that's a really common indication for pregnant patient population we'll talk about tomorrow. All right. So with that, I thank you for your attention, and yeah, I'll defer to Carly for if we have a couple minutes for questions or not. Thanks.
Yeah, definitely. There's one question already in the Q&A, so we have some time. You can go ahead and take that.
Sure. Yeah, I think I see this. This is from Dr. Krebs.
Mhm.
You've shown AP plus lat, water equivalent diameter, effective diameter in some of your plots. Do you recommend one of these over the other in developing protocols? So for developing protocols, I don't, and I'll say why. So like if I go back, how do I go back? Yeah, like here, we actually noticed a fundamental shift between our patient size surrogates at MD Anderson and UW, even though we told the dose monitoring systems to tell us the same thing. So like, do I really trust that all the dose vendors are implementing all of these things the right way or in the same way? I know they're not implementing them correctly and in the same way. So what I can trust though is they are implementing them in some way that shows a monotonic like increase as like the patients get bigger, their metrics get bigger. So as long as you're using some metric like that, that's what you really need to care about when you're optimizing these parameters and looking for problem areas. You know, who really cares exactly what these specific values are at the end of the day? I think what you're using this for is a way to view your data that lets you identify the problems like I talked about today, not so much that there's one that's like fundamentally better than the other. In practice, water equivalent diameter is probably, if I had to pick, because it's the best, because it's usually going to have the tightest distribution of dose, because that's the closest thing to what the CT vendor's black box AEC algorithm is going to use for their dose calculation.